Well, hello everyone, and welcome to this practice session of Pros on Demand. And this is brought to you by One Team Professionals. And today we're going to be talking with our featured coach, Stuart Hawley, with the Hawley Group out of Tulsa, Oklahoma, and also out of Oklahoma City, Oklahoma. And Stuart, we're so glad to have you here with us today, and glad you could join us for this practice session.
Certainly. Is my speaker working?
You are on. You're good. You sound good.
Very good. Thank you. Hi, Michael. Hi, Ryan.
We're going to kind of break down. You are our coach expertise in group health and benefits, and we're going to kind of break down just a couple of things today. There's a lot of moving parts, and we're not going to swallow the whole elephant in this practice session a little bit. But I think we kind of want to talk a little bit about maybe how we can help educate the small business owners, the HR people, the ones that typically maybe even be the gatekeeper of group health, and they kind of manage that a little bit from a business standpoint. And you've been doing this for a long time, and I know you've seen a lot of different situations, different things over the years. But let's kind of dive into this a little bit, and kind of the approach in really how you try to educate, teach and train, if you will, a business that you come into contact with and are working with.
Well, what we find is that a lot of people, and certainly in certain industries, they have a bid mentality because they're forced to bid their product, their service on a regular basis. And that's certainly true in the construction world. And it's certainly some kind of an overwhelming thing to get them to realize that health insurance, employee benefits are not necessarily a bid product. Certainly not true in the small group space under 50 lives in Oklahoma. The rate is the rate depending on just the industry and the ages of the group. So the genders don't even matter anymore.
All right.
So it's hard to convince them that they don't really need to go out to bid, but all of the bids are going to be identical if the same information was given. In other words, if the census is the same.
Yeah.
So, none of us need practice quoting.
Right.
And so I just try to, the legwork of teaching them how to buy our product, find and interview a good representative, someone you trust, call the references, and then hire that representative to go get the quotes.
Yeah. Yeah, I think that's really the key phrase there, is that you're not bidding on the insurance per se, but you're hiring an agent to really do that for you. Because even coming from the P&C world in the insurance, I think when you talk to business owners, typically the mindset is I've got to get the best price. That means I've got to go to 2 or 3 different car dealerships, if you will, if I kind of put it in that sense. Right. And, kind of get a bidding war going against each other and that type of stuff. But that's really kind of what you do, in the sense, once they hire you as the agent, correct?
Exactly. And that's certainly true of the under 50 space. When you go over 50, then arguably you might want to get another opinion in that I know in the P&C world, you may have markets to 25 carriers, and another broker may have access to 25 carriers, and most of them overlap, but there might be a few that are different in both categories. In our world, we could go to third-party administrators and prescription benefit managers that have different price points or pricing. And, but if we're just going to get large group quotes through fully insured carriers, they all have to be the same also.
Yeah,
So we don't often compete with a bunch of other brokers. Our competition is kind of, as you had said, we visit with the owner, the decision makers, the HR people, and then discuss with them, you know, have you vetted me, vetted our agency, call my references,
yeah,
hire a rep, and then let us go to work for you.
yeah. Is there a process too, Stuart, and uh, used to, and the limited things I know about group health and different things, but there used to be kind of a carve out for management or different things, and explain. Let's start with this. Explain discrimination or non-discrimination as it applies to group health.
As long as they're definable classes and not nothing in the gray area, then you can still have different either price points, plan designs, or contribution levels in those definable classes. So I, we probably have some people doing salary hourly, which really isn't as definable as we would like. If they're in a
Right.
managerial role or versus a rank and file, that's a pretty clear distinction. And as long as you don't just call someone a manager so that they get a better or higher rate of contribution towards that benefit. The only rule is that if you offer, uh, let's say you pay $400 of a $450 premium, but then there's a richer plan that's $500, as long as you allow anybody in one of the other classes to buy up the best plan, then
Right.
you're still meeting the requirement. You can't exclude others from buying the richer plan, uh, but you can certainly charge them for that cost of the richer plan.
And as an employer, you get to determine or the participation rate. I mean, it has to be at least 50% for an employee, up to 100%. Or is that?
That's still true. Most of the contracts still say that the employer has to contribute at least 50% of the employee portion of the health plan, but they could contribute 50% of the lowest cost plan if you were to offer two or three different plans. There, and the only caveat now is the ACA, the Affordable Care Act, requires that they that it's affordable, and these are groups over 50,
Right.
and you have to pay less than 9.5% of the lowest paid, can't be more than 9.5% of the lowest paid employee's salary or wages. So you have to kind of watch your contribution, because almost every employer has a 12 or 13 or $14 hour an employee that meets a full-time equivalent, and the premium cost can't be more than 9.5% or 9.75%. I think it may have changed. Their
And
contribution can't be more than that. So
yeah, and what's the full time qualification? Is it
you
by
get to
hour
define
or by salary or?
hourly. You can go as low as 24 by state law, and you can call full-time 40 employees. So most most people are using 38 or 40 hours because the cost of the health insurance is just so expensive that they're trying to
Right,
cover the ones that need to be and want to be covered, but not
right,
not the others.
right, right. So how do you typically have kind of a training with a business when you go in and maybe they're wanting to make a change, or you've come in and presented some ideas to to a particular business. Do you go in and have a real evaluation time, or how do you what's that process look like?
Yeah, we go in and ask some real, basic questions. Are you, who are you with? When is your renewal date? Uh, what what's working for you? What's not? Have you seen various companies? What networks work for you? And try to find a, some sort of glitch in the current brokers
Yeah,
offering. Either they're not shopping the market, which is probably the most common, where their broker tries to place all of their business with one carrier because they get either bonuses or other considerations that are within the boundaries of the law. But so they try to keep all their business with one carrier. Plus, it makes their platform much easier to understand, and they don't have to think about the answer as much because
right.
the rules are the same with that carrier. Uh, and then the compliance portion. I mean, most of these companies we run into don't have what's called a wrapped document. They don't have all their benefits in one place, and every group 2 and above is required to do that. Now, probably won't get us but any more than a slap on the hand, but
So explain that a little bit. The wrap document. What is that?
well, it's basically putting all of the benefit offerings, the medical, the dental, the life, the disability, anything that they're offering in one ERISA plan. I guess the easiest way is an OSHA manual.
Hmm.
If you're a manufacturer or a business, not so much us in the office, but where you have a policy and procedure for, you know, a wash station, and where your fire extinguishers and the safety protocols. This is basically all of the employee benefits in one package that's accessible to the employees. The employees have access to the document either through their intranet or we're given a copy so that all the employees know the summary plan descriptions. They have they have they have a total understanding, if they wanted to go read it, of all the benefits that their company is offering. And we just put it up in a notebook and then on a thumb drive for that purpose. When the Department of Labor comes in and wants to do
Yeah.
a DOL audit, you can pretty much just hand them the book and they just walk away.
Yeah.
Okay.
Have
And
at
they'll
it.
go
There
find,
you go. Yeah.
yeah, and they'll go find someone else that's not in compliant because
Right.
it's too easy to find people that aren't.
Yeah. Is that something that you find that you do that others don't?
We do. We buy software and do it for a fraction of the cost. Most of the law firms will charge $1,000 or $2,000. Online, we found it for 900 to 1,000. I think we're charging $175 for that wrap document. You don't need to update it unless they make a plan change, a benefit
Yeah.
change or something, and we have a renewal fee. But that gets us in lots of doors, Michael, uh, as it relates to that, because no one they don't like the word audit.
Right.
And uh, that's just an insignificant cost to an employer to spend $175 for a wrap document and a thumb drive to
Sure.
basically get someone just to go away.
Yeah. Yeah.
But
I mean, that's an annual fee. I mean,
yeah, well, the annual
175.
fee, 50 or $60 to renew, but no,
Right.
it's just a lot of work the first time. But we will renew that, and quite honestly, we would do that. You'd have several days to comply.
Right.
If someone walked in, they're not going to just fine you. They're going to go, well, we're going to be back in 10 days. You need these things. And we can create the document after you've had the visit. But and we don't charge more because you're under duress, if you will, but
Right.
we can still create the document. and we'll create a document that's not our client, but hopefully we'll have the opportunity to bid on their benefits when they roll around.
Yeah, yeah. What about, how do you deal with, and I know with health insurance, it seems like every year, 15 to 20% used to be kind of a standard increase in that. How do you deal with that from year to year? Do you kind of find a typical carrier that you can work with, your relationship with the underwriters? How does that change very often with
Well,
you and your clients?
I just had a renewal on a big construction company at noon, and they got a 16% rate increase. And so it's either achieved through reducing the network, having a narrower PPO network
Right.
where the insurance carrier can control cost in a smaller network. And that's in fact what we did on this group. They had a broad network. We went to the carrier's narrow network. We had done they have 134 employees. We checked all of the doctor visits in the last 12 years, 12 months with the narrow network. And we had I think it was a 98.6% coverage. So that's a reasonable accommodation.
Yeah.
So someone out there is seeing a doctor that's not in this network, but certainly not gross negligence on the part of the employer, and got his renewal to 7.5% by down, in other words, about 9% reduction by utilizing the network and verifying that virtually everybody's already using those physicians anyway.
Yeah.
So that's one approach. The second, unfortunately, is cost shifting, where the employers are going to higher and higher deductible plans to make the benefits somewhat affordable. And part of that is justifiable if you just take simple inflation and the value of the dollar, but it still doesn't make it any easier for someone who has a $2,000 deductible moving to a $3,000 deductible. They don't feel like they're making $3,000 worth of income the next year versus a $2,000 deductible. They don't feel like they got $1,000 raise.
Yeah.
And unfortunately, a lot of people are not getting raises because the cost of health insurance is going up.
Yeah. And brings to another point, a thought here too. So how has technology affected rates or management in that sense? I know, a lot of people use a teledoc, or they communicate a different way rather than actually going in and, seeing the doctor, but there's a different way of doing that. I don't know if that's the right terminology, but can you speak to that a little bit?
Telemedicine's been around a long time, but
Right.
no one knew anything about it. A lot of people didn't know anything about it until the COVID hit.
Right.
But it's been around 20 something years. We now I think all the carriers still have some sort of a COVID clause that they're allowing you to visit the network of doctors with a $0 or very minimal dollar copay with a televisit or a web visit with your physician. We've been selling for years a standalone telemedicine product that has a $0 copay, and that has gotten even more traction over this year. But I would say most of my clients have telemedicine that they bought in addition to their health insurance.
Okay.
And ours covers the entire family, whether they're on the health plan or not.
Wow.
So for a very minimal fee, we can get you covered and your whole family, whether they're on your health plan or not. And then it's just a matter of messaging to drive up utilization. If you really look at medical claims, about 70% of what we see the doctor for, you could do over the phone.
Right.
And I remind people that their veterinarian seems to be able to treat their dog, their cat, their rabbit, their llama, and those animals can't talk.
Right.
Well, how do they do that? Well, they examine and they talk to the owner, but it's just through an examination, and we can have a conversation with our doctor how we're feeling, what our symptoms are, you know, and
What hurts and where? Yeah.
yeah, and so if a veterinarian can do it, hopefully our doctor can do it, and you don't catch something else in the office. It's very time efficient for both or all parties, and they can prescribe over the phone. It's good in all 50 states now. It is certainly the way it is headed as far as
Yeah.
medicine.
Yeah. Yeah. I mean, always seems to be a little bit better mousetrap or efficient way of doing things or diagnosing things. I mean, it seemed like there's always somebody that wanted to run to the doctor for every little ache and ailment and different thing. But that's certainly a great way to help manage those costs and lower the claims.
Yeah, they can they can do it on their cell phone a lot of times, driving to their next appointment or in their commute, and explain what's going on with them. Uh,
Yeah.
there's only 2 states require still a FaceTime or video call like we're doing. In all the other 48, you can just do it over the phone without a visual feed. But I mean, many examples of taking a picture of a spider bite or a rash or taking pictures now. They've got little camera uh, lenses that fit on your cell phone. You can take pictures of your inner ear, your tonsils, and send those pictures to the physician you're talking with.
Wow.
That can diagnose that. Of course, these smart Apple type devices on their wrist, they know their heart rate, they know their pulse, they know, and then of course the newest ones have glucose monitors and all
Yeah.
sorts of things, so that you really can paint a very accurate picture verbally of the condition and what you're experiencing for a really accurate diagnosis.
Yeah. Yeah. No, I absolutely. I mean, there's so much technology that's available at our fingertips, and we carry it around in our pocket most of
Yep.
the day, you know. So that kind of gives you a big head start and a great help to the doctor because they can check all that stuff.
Yeah. I mean, the emergency, the ambulance ride, they're transmitting all of that data that they're gathering on the way to the hospital,
Sure.
so they don't have to start at square one again. They know the pulse. They know, they already know what medications have been administered to the person in
Yeah.
the ambulance. And so this is just uh, really seeing a tremendous number of things being treated over the
Yeah.
phone.
Yeah.
Uh,
Yeah.
but
Hey.
the way we sell it, Michael, is basically it's time and attendance. I mean, we have it in our office, and uh, my person in Oklahoma City, Ashley, I mean, she basically pays for the whole thing for everybody because she has 2 little boys, and they're always getting into something. And she and her husband solve the problem at night, and she's at work the next day.
Right.
But the cost, the time and attendance alone pays for the
Sure.
cost of the telemedicine.
Yeah. Absolutely. Yeah. I mean, and that makes a big difference in, uh, like you say, production at work, time off, or not taking a half a day or a day here or there just because you've got a little ailment or something. So yeah, that would well take care of that cost, repay itself several times over.
Yes.
Yeah. There's a lot of different things, and we'll talk about more things as we get into. I mean, there's a lot of moving parts with group health and all the ancillary coverages that we haven't really talked about yet, different things like that. So many different things that we'll be able to get into the next time that we have practice session. But just want to take this opportunity to thank you for participating today. And I want you to kind of hang on here just a little bit. We'll have an opportunity for some questions and discussions. And we'll just take a quick break here, and we'll be right back right after these words from our sponsors.
Thank you, Michael.